For years, Brazilian private healthcare lived inside a comfortable fiction that denying a procedure, a surgical implant, or a medical technology was just paperwork, an administrative act. It is not. Here is how it works. A surgery is pre-authorized by the health plan. The hospital opens the operating room. The distributor delivers the implant. The surgeon operates. The patient recovers. The invoice is sent. And then the payment is denied, retroactively, after everything already happened. In Brazil, this is called glosa, and it is not a documentation dispute. It is a transfer of economic risk onto the people who least control the system: physicians, hospitals, and medical technology distributors. In November 2025, Brazil's Federal Council of Medicine, the CFM, published Resolution 2.448. Its goal: to regulate medical audit as what it actually is, a medical act, not a call center, not a spreadsheet checklist, not data processing. The resolution says something obvious that the market pretended not to see. If audit is technical, it cannot be operated as a financial weapon. And the market's reaction? Several provisions were immediately suspended in court. The fight started on day one. The resolution targets a brutal asymmetry. The attending physician answers for the patient, legally, ethically, personally. The auditor interferes with the treatment decision, often without ever examining the patient, without speaking to the physician, without assuming any clinical risk. The health plan captures the savings. The distributor loses the receivable. The hospital freezes the bill. And the patient is caught in the middle. When someone can override a medical decision without carrying its responsibility, that is not regulation. That is responsibility laundering. And here is the mechanism that corrupts everything. In parts of this market, auditors are paid more when they deny. Resolution 2.448 prohibits linking auditor compensation to denials, because even a competent, honest auditor cannot produce neutral analysis inside a system that rewards no. In medical audit, a misaligned financial incentive is not an accounting detail. It is a patient safety risk. In June 2026, an investigative report exposed what the market discussed behind closed doors. Companies branding themselves as health technology platforms operating, in practice, as industrial-scale private audit structures, one market leader reportedly reaching 24 million beneficiaries, nearly half of Brazil's privately insured population. Worse, according to the report, health plans were getting prior access to independent medical board opinions before the tie-breaking physician even signed them. Think about what that means. The referee's decision, reviewed by one of the teams before it's published. A medical board only has value if it is independent. If the paying party validates the opinion first, it is not a tiebreaker. It is a staged neutrality. The question is not whether health plans can audit. They can, they should. No system survives without controlling waste and verifying indications. The question is another one entirely. Who audits the auditor? Today, in Brazil, that question has no sufficient regulatory answer. For medical device manufacturers looking at Brazil, this is the lesson most market entry playbooks miss. Regulatory clearance is not access. Coverage is not access. Even prior authorization is not access. If a post hoc audit can reinterpret the case, deny the payment, and strand your receivable. The Brazilian market is not blocked by sanitary regulation. It is blocked by opaque audit flows and misaligned incentives that put the treasury before the patient. Without payment predictability, innovation does not scale. And without ethical, transparent, independent audit, there is no real access. When audit stops being a technical instrument and becomes denial engineering, the whole system gets sick. Read the full analysis at hitconsult.com.br. HIT, Access Engineered.